Welcome you all to today's case discussion and learning of parasites. Let us learn it with a case. A 48-year-old man being treated for colon cancer with an aggressive 6-month 3-drug combination chemotherapy regimen begins to experience fever, headache, confusion and seizures. He has had several indoor cats as pets for last 20 years. A diagnosis is made based on characteristic clinical and radiographic findings. The patient is treated with a combination of pyrimethamine and sulfadiazine. Now, this is a case for Toxoplasma Gondii. Now, before we move ahead in this session, I would just like to give you a good news or share you a good news about this Parasitology simplified ebook which was there. Now it is available on various platforms like ocular.co.in website. It is also available on all the Amazon websites, and it is also available in Google Play Books. The book is also available in paperback hard copy formats on amazon.com. So this video series that I'm doing is a part of supplementary tutorials to this book. So all the diagrams and tables and charts that you see in the presentation will be there in the book. So let us start today's case, that is Toxoplasma Gondii. Now toxon means arc, and this name has been come from the curved shape of this trophozoite as it has been shown here. And Gondii was the North American rodent in which this parasite was first described. Geographical distribution: most common protozoa worldwide, and it has widest host range. Morphology: it has 3 morphological forms, and interestingly all the 3 forms are infectious to human beings. We have discussed in earlier parasites where only 1 form was infectious, but here all the 3 morphological forms are infectious to human being. Now it shows asexual morphological forms and sexual morphological forms. So asexual reproduction, it is usually seen in intermediate host, but it is also seen in definitive host. Definitive host for this parasite is cat, and intermediate host is usually humans or rat. And sexual reproduction, which only happens in definitive host, which is also known as sporogony or gametogony, and it is only seen in definitive host. So what are the asexual reproduction forms? They are trophozoite and bradyzoite. Now trophozoite, they are rapidly multiplying forms. Bradyzoites, they are slowly multiplying forms. So sometimes within infected cells, when trophozoites are growing, they give you a cyst-like appearance, but it is a false cyst. That's why we say that trophozoite, they usually form the pseudocyst, and bradyzoites, they actually form the true cyst. So within the tissues, they form a collection of bradyzoites, and around which there is a cystic layer is there. So bradyzoite form the true tissue cyst, and the sexual form is oocyst, as you can see here. Trophozoite are also known as tachyzoite. Tachy means fast because they can multiply fast, they can replicate fast. It is a crescent shape parasite, and it is usually seen in acute infection. It has an apical complex, as you can see at the pointed end. It has an ovoid nucleus on the blunt end side, and when you stain it with Giemsa stain, you can see the nucleus, which is seen in red color, and the cytoplasm will appear blue in color. This form is very delicate. It is susceptible to drying, freezing, thawing, as well as gastric digestion. So this extracellular trophozoite, they invade any nucleated cell or host cell, and then they replicate within cytoplasmic vacuole by endogeny, or also known as internal budding, and 2 daughter trophozoite, each surrounded by a membrane within a parent cell. And such rapidly proliferating trophozoites or tachyzoites, which are enclosed by host cell membrane, it gives a false appearance of cyst, and that's why we call it as a pseudocyst. and when the host cell is distended enough, it will disintegrate and release all the trophozoite again into the external environment. The second morphological form is bradyzoite, which usually form the tissue cyst. Actually, the bradyzoites, they are usually oval in shape. They are slightly larger, 10 to 20 micrometer, and they are resting form, and they are usually seen in chronic infection. So acute infection, trophozoite; chronic infection, bradyzoite, and they are usually found in brain, skeletal muscles, and other internal organs. So what we have learned so far, that there are two types of cyst: tissue cyst and pseudocyst. Tissue cyst, they are made up of slowly multiplying trophozoite form, which are also known as bradyzoites, and pseudocysts, they are made up of rapidly multiplying trophozoite, which are known as tachyzoid within a host cell. The cyst wall, however, is eosinophilic in case of tissue cyst, while it is not eosinophilic in case of pseudocyst. You can stain the tissue cyst wall with help of silver stain, while pseudocyst will not would not take any kind of silver stain. So this is how actually in vitro you can also identify whether it is a tissue cyst or a pseudocyst. The third, or the last, or the sexual morphological form, which is known as oocyst. It is oval in shape, as you can see here, 10 to 12 micrometer in size. It has a very thick resistant wall, and it is formed by sexual reproduction, and as you know that sexual reproduction can only happen in the definitive host, and that is the cat. So it develops in the intestine of definitive host. But the freshly passed oocysts, they are not infective. They undergo development or sporulation in soil, and they develop 2 sporocysts, and in each of these cysts there are 4 sporozoites. So total one oocyst will contain 8 sporozoites, and this is the main infective form, although all 3 can be infective forms. Now come to the heart of the parasite, that is the life cycle, and we know that to understand the life cycle, first we have to go through the host. So definitive host is the cat, in which both sexual as well as asexual cycles will happen, and it is usually seen in intestine. While an intermediate host, which is usually rat or birds, but accidentally human also, in which only asexual cycle is seen, and it usually happens outside the intestine. So let us see what happens in definitive host or cat in their intestine. So usually the cat get infected when it eats the rat or birds, and in rat and bird tissues there are tissue cysts with bradyzoite, or sometimes cat may eat its own feces. I know it's disgusting, but sometimes it does so, and in that case oocyst in cat's feces may be the infective form for the cat itself. So in either case the bradyzoites are released in small intestine of the cat. We are considering the first scenario to be more common. They undergo asexual multiplication and form the merozoite, and this merozoite, they enters into the extraintestinal tissue, and they form tissue cyst in the cat. But some may transform into the gametocyte, micro as well as macro gametocyte. The macrogamete is fertilized by microgamete, and it form a oocyst, and we know that freshly passed oocysts are not infective. It will be released into feces, and it undergoes sporulation in soil, and it develops 2 sporocysts. This is a sporocyst in which there are 1, 2, 3 and 4 sporozoites are there, and each oocyst has 2 such sporocysts. So one oocyst will have 8 sporozoites. Now what happens in intermediate host? Exo-enteric cycle in intermediate host. The mode of infection to human can be from 2 modes. Either we get infection from animals, or we can in fact get infection from other human beings. So let us see first scenario, animal to humans. That means if we eat uncooked or undercooked meat containing the tissue cyst, usually the bird meats, right? And ingestion of food or water contaminated with oocyst in cat's feces. If your food and water is contaminated with cat's feces which contains this oocyst, then also you can get this infection. Human to human, the most common mode is congenital toxoplasmosis, that is intrauterine transfer from mother to fetus. Blood transfusion or transplantation of organs which are already infected, that can also be the other way. Human infection is a dead end for parasite. Full natural cycle is maintained between cat and mice. So we are actually the accidental host. But sporozoites from oocyst and bradyzoites from tissue cyst enter into the intestinal mucosa. They multiply asexually. Tachyzoites are formed. Tachyzoites multiply. They spread by lymphatics and blood and go to the extraintestinal organs. The common organs are brain, eye, liver, spleen, lung, muscles, and here they form the tissue cyst. And this tissue cyst consists of slowly multiplying trophozoites, which are known as bradyzoites, and they remain viable for years. And whenever you get immunocompromised, or whenever under any condition your immunity goes down, these bradyzoites get reactivated and they form trophozoites, and then the renewal of infection will happen. So this is a CDC diagram which you will also find in the book. It is just simplified everything. The definitive host is cat, which releases the oocyst in feces. These oocysts mature in soil, and this feces containing oocyst while grazing in the field, it will be eaten up by rat and birds, and they develop tissue cyst which will be eaten up by cats. So this is the normal cycle, but somehow when we starts to eat the animal meat, we also eat this tissue cyst and get infected, and from human to human it gets either from mother to fetus or via blood transfusion, or sometimes there's some people who have cat as pets, as in our case. Their food or water may get contaminated with cat feces knowingly or unknowingly, and they will develop this disease. So what could be the pathogenicity? Pathogenicity is known as toxoplasmosis, and most common presentation is asymptomatic presentation or asymptomatic toxoplasmosis. That means patient does not know and it does not have, he or she does not have any kind of symptoms. But other modes are congenital, acquired, ocular, and immunosuppressed toxoplasmosis. So let us see them one by one. So congenital toxoplasmosis results when Toxoplasma gondii is transmitted transplacentally from mother to fetus. And this occurs when mother gets primary Toxoplasma infection, whether clinical or asymptomatic, during the pregnancy. And pregnant mothers which have this Toxoplasma infection, and because pregnancy is an immunosuppressive state, and this tissue cyst may sometimes get reactivated if mother has a latent infection. The risk of fetal infection, it rises with the progression of gestation. For example, in early pregnancy the risk is 25% in first trimester, but it goes up to 65% in third trimester. But interestingly, the severity of fetal damage is maximum in early pregnancy, while it is very less in late pregnancy. And most infected newborn, they are asymptomatic at birth, and they show clinical manifestation weeks to years after the birth. So what are these manifestations? So I have divided them into 4 different categories. One which involves brain, eye, reticuloendothelial system, heart, and other manifestations. So in brain, it causes cerebral calcification, convulsions, mental retardation, deafness, microcephaly, hydrocephalus. In eye, it causes chorioretinitis, squint, blindness, microphthalmia, cataract, glaucoma, lymphadenopathy, hepatomegaly, jaundice. It can also be seen, and myocarditis, fever, petechiae. These are the various manifestations of congenital toxoplasmosis. So here I have shown you the ventriculograph of skull, and as you can see, there are calcification in ventricles. So cerebral calcification, you can see a child with hydrocephalus. So these are all manifestation of congenital toxoplasmosis. Sometimes it only involves eye, and then we call it as ocular toxoplasmosis. It could be seen in children, it could be in adult, and usually it is uveitis, choroiditis or chorioretinitis, as you can see here. And sometimes it may be so severe that it require removal of entire eyeball, that is known as enucleation. Acquired toxoplasmosis, that is after birth, it is acquired postnatally. The most common manifestation is lymphadenopathy, and most common lymph node which are involved are cervical lymph nodes as shown in the picture. Fever, headache, myalgia, splenomegaly, and self-limited mild flu-like illness can also be there. And some people may also show typhus-like exanthema, which may complicate in pneumonitis, myocarditis, sometimes meningoencephalitis, which can be fatal also. If a person is immunosuppressed, then for example AIDS, then most serious and most fatal illness can be seen, and the most common organ involved is brain, in which you will see encephalitis, altered mental status, seizures, cerebral signs, meningismus, neuropsychiatric manifestations. But it is not that only brain is involved, other organs can also be involved like lung, pancreas, gastrointestinal tract, eyes, heart, liver, and sometimes Toxoplasma pneumonia. And why I'm saying that, because in AIDS, when we say pneumonia, the organism that comes to our mind is Pneumocystis gondii pneumonia, but this could also be one of the cause. If you see the CT scan, then you will see ring shape enhancing lesion on the contrast CT scan in case of cerebral toxoplasmosis. Immune response, the humoral immune response in form of IgG, it will act only on extracellular trophozoite. It cannot kill the trophozoites which are within a cell. Cell mediated immunity is very important to kill the intracellular morphological forms, and in which T cells and natural killer cells play a major role. How to diagnose in lab a case of Toxoplasma gondii? So there are, I have divided them into three portions: microscopy, serology, which is the mainstay of the method, and other. Microscopically, you take the sample, usually it is in blood, so you can take blood, sputum, bone marrow aspirates, and with help of GIMSA or PAS or GMS, or that is Gomri methamine silver, you can stain those films and show them either bradyzoites or tachyzoites. It is as simple as that. But the mainstay of diagnosis is serology. Now here we can detect either antibodies or antigen. Antigen detection is usually with help of ELISA. IgG, IgM and IgA can be detected with ELISA or other methods. IgG detection, it is useful after 2 to 3 weeks of infection, but it reaches peak level at 4 to 8 weeks of infection, and the titer which is significant is more than 1 to 10. And IgM detection, it is mainly for acute infection, while IgA detection is very useful in case of congenital toxoplasmosis. Other infections detection methods are PCR. B1 gene detection in amniotic fluid can be very useful. MRI or CT scan to locate the lesion. Ultrasonography to detect anomalies in case of congenital toxoplasmosis. Animal inoculation, skin test, these are obsolete tests. Skin test of Frankel was used in earlier days to detect delayed hypersensitivity after 48 hours of injecting the Toxoplasma antigen into the forearm. So these are the microscopic pictures. This one is stained with GIMSA, as you can see. This one is again with hematoxylin and eosine, and it shows the cyst. And this is a new method, that is immunofluorescence, which is showing the tachyzoites. Sabin-Feldman dye test. This test is obsolete now, but again to complete the laboratory diagnosis, what is the principle of this test? That if a patient has antibodies, it will inhibit the staining of trophozoite by the dye. So what we do, we take patient serum, we add to it the trophozoites, and then we add normal human serum, incubate it for 1 hour, then we add a drop of dye, and then we examine under microscope. If patient serum has antibodies, then what will happen, that it will not allow the trophozoite to get stained. So if you see less than 50% of tachyzoites or trophozoites are stained, that means the result is positive. But you see that most of them, 90 to 100% of them are stained, that means patient does not have any Toxoplasma antibody. What could be the treatment for Toxoplasmosis? Treatment for Toxoplasmosis: in case of congenital Toxoplasmosis, you can give pyrimethamine and sulfadiazine, and both this drug will decrease the folic acid level, so we will also give a supplement of folic acid for 1 year. In case of immunocompetent patient who has only lymphadenopathy, nothing is required as such unless very severe symptoms are there. Otherwise, in case of ocular Toxoplasmosis, pyrimethamine and sulfadiazine or clindamycin for 1 month can be given. Prophylaxis. It starts with cat feces, so avoid contact with cat. Proper cooking of meal, hand washing, screening of blood and blood products. There is no vaccine which has been developed yet. Difficult to control due to wide range of reservoirs. Any animal or bird could have it. But specific prophylaxis, for example, in case of immunosuppressed patient who has CD4 count less than 100, as in case of HIV, you can give prophylactically cotrimoxazole or dapsone pyrimethamine, and you can discontinue this prophylaxis when CD4 count boosts up to 200 or more for 3 months. So in next session we will do acid fast protozoa, that is Cyclospora, Cryptospora, Isospora and Microspora. Till then, goodbye.